So my interest in survivorship actually dates back to probably about 2014 specifically, because I went to ASCO, which is the American Society of Clinical Oncology. It's one of the big international conferences where they get about 40,000 people from all over the world. And they present all the latest stuff. A lot of people keep the most up-to-date stuff to present because it's quite prestigious. And I saw, when you get to register, you can actually have a look online, see what's actually on there. And there was this thing about survivorship, and it was like a program that you could go to. And so I thought I'd just go to that because I heard a little bit about the concept. And it was actually really good because it was one of the lead clinicians who started the survivorship program at the MD Anderson. And so for those of you who actually don't know what that is, it's a very large international cancer centre where they do lots of things very early. It's quite a prestigious hospital to sort of work at, and it was quite inspiring because it was clear to me that it was sort of something that made sense. I think any person that's worked with people with cancer recognise that, initially there's a lot of focus on the disease itself. That's often, at least historically, how people would manage people, but it's pretty clear that it's got a huge impact. Has lots of repercussions, both emotionally, not just for the person, but for their family and the finances. And although I think innately we might do some of this stuff in pockets, the system's not necessarily there. So sometimes things slip through. And so it sort of inspired me to actually think about establishing something within Bendigo Health, which is sort of what we've done. We've established a survivorship clinic. And so there's actually a fair bit of overlap with some of the things that I've discussed here. I think one of the things about it is it's got multiple aspects to it. The other thing about health is that people move around. They move from their GP to one specialist to another specialist to allied health. And I don't know about you, but I get snippets from the patient and maybe little bits from letters, but I really don't know what's happening when they go to see their OT. They might get a letter, but maybe I don't. And it's probably vice versa. So it is very challenging because they move around, but that's unfortunately how it works. And so having some sort of common pathway, I think, sort of makes sense, and it also potentially reduces the chance of duplicity. Again, this concept of survivorship or survivor, I'm not going to go into in great detail. I think the point of it is that it's varied. Some people say it's a diagnosis. Some people say that it's when they've been told they're all clear. Some people say that it's at the end of their active treatment if they're in an early stage, for example. I think that it's a bit of a moot point, but I think the reality is that it's about identifying problems that a person that's having outside of the disease. And I suppose the other thing that about this is that, as has been described, it's common. There are lots of people with malignancy. There are lots of people who are in this situation. And, this is an example of the most common malignancies where people are potentially cured from their cancer, but also have to deal with some of these chronic issues of either the disease, whether it's on the impact on their psychological aspect, or whether it's an aspect of the physical changes or the treatment that goes along with it. I think what's stipulated as well is that these are the common things that people talk about. Fear of recurrence is certainly very high up there, and it's not necessarily based on their risk of recurrence. So there are some people who have a very high risk who might cope with it quite well psychologically, and there are other people, and it was a bit like I was alluding to before, where actually their risk of recurrence is extremely low, yet the fear of recurrence probably causes them more morbidity than their actual cancer or treatment, and it can be very challenging to actually address it in a successful way with all people. There's the physical aspects of the treatment, and again, chemotherapy always gets, gets the bad reputation, although we do have some actually very successful non-chemotherapy drugs, but it is true that there can be some side effects. But the other thing that I also feel is that some of these people come with issues before. That concept of cognition, there was a study where they actually looked at it, and people before they had chemotherapy had cognitive impairment already. What often happens though is they have a problem, they've had chemotherapy and it's a good escape. The radiation oncologists do it all the time. They blame us for, side effects. That's probably their treatment, but anyway. But the point is it's an easy way to objectify stuff. I feel like this because of the treatment, but sometimes, some of these people have very bad understandings of nutrition. They've never been healthy, that they didn't start in a good place. And so nonetheless, we've got these aspects of physical impacts of treatment. Of course, there are late effects. And again, you've touched upon them today, things like peripheral neuropathy, which can have quite significant impacts on their functionality, the emotional and psychological effects, relationships, and it does strain relationships. There's been a fair number of people that have undergone divorces because the partners just find it a struggle, and again, it probably just precipitates a problem that was there before. Sexuality, big aspect, and we'll talk about that down the track. Financial and vocational, it disrupts people's educational opportunities, it makes their work difficult, and there's also, you know, difficulties of actually moving on after the event. This is an interesting statement. The IOM, which is the Institute of Medicine, which is actually an organisation in the States, what they basically said is that they actually stipulated in 2005, so we're now 13 years down the track, where they stipulated at that point that there was a requirement for a survivorship care plan. And in fact, there are some hospitals in the States, if you don't have a survivorship program, you don't actually get, your hospital isn't actually accredited. So it was actually identified quite some time ago that it was something that was going to be important in terms of providing quality care. And so what this statement actually said is, and again it was sort of alluded to in that statement on the video that you said, that this program needed to contain a degree of prevention. Okay, so when we're looking at people who've got cancer, we want to obviously prevent it. If you look at the cancer website, approximately a third of cancers are actually all preventable. So they don't even need treatment. So if people had appropriate screening, if they, they reduced their tobacco, alcohol, all that sort of stuff, you could actually cut out a third of cancers and never have treatment if you did that. But unfortunately, we often focus on the disease because the prevention's hard to do. That there has to be appropriate surveillance. This is a bane of my life. We have a lot of duplicity. We have stuff where people get seen by one specialist and 4 weeks down the track they see somebody else. Waste of resources. And it's because of the communication's not great or it's not appropriately coordinated. And equally, there's lots of stuff that could be actually shared with the general practitioners in terms of the surveillance that wouldn't need to be done in the hospital. And there's been papers that have looked at women with surveillance breast cancer treatment that they do just as well with their general practitioners. Having said that, when I've talked to GPs about it, they say we're busy too. So you have to get the middle ground there somewhere. That obviously there are things that need to be done to, problems need to be addressed, so the interventions, and that's where I suppose our program goes into, which Rob will talk about in great detail, but this concept that there is a whole plethora of issues that arise that you need to identify and then appropriately manage or refer. The challenge is as you get more rurally positioned, the resources become less. The people, the clinicians, have to actually be broader in their expertise, and that's, I think, where the difficulties lie upon. If you look at the resource distribution, it is not evenly distributed. And I'm not going to name names, but I did actually train at one of the centres of excellence in Melbourne, and the resources that they had was just phenomenal. I can remember we used to do ward rounds on haematology ward rounds where all the consultants, all of the allied health, pastoral care would all go together and look at every single patient. Well, if you all had those resources, you'd be a centre of excellence too. Nonetheless, that's not the way that it is. And you need to have coordination. And I think that's the other issue, that, when we do have things that fall apart, it's not often because people don't have the skill set, but sometimes it's because the coordination fails or people fall between the cracks. So the concept was that we wanted to actually put together some sort of survivorship care plan. And again, Rob will go through it in greater detail, but the idea is that firstly you have some sort of component that summarises what they've actually had done. That you basically also had a list of all the problems from the treatment, that you had recommended screening programs, that you had some sort of needs analysis to actually look at what the problems are, and that you also provide the patient with a clear follow-up plan and also sources of information that they could get. The barriers in some respects is that this is sort of an evolving area, I suppose, and it's interesting when we were trying to put together our own survivorship program, I was looking for other places where it had happened in Melbourne, thinking I could just get the recipe and just follow the recipe and not have to reproduce the wheel. But it's interesting, even within that space, people within places like the Women's, the Western, the Austin, sort of did things that had similar components, but they were also not, you couldn't just take their program and take it because it's still in evolution. The other issues is that, as I said, there's not an ideal guideline, but I think it's starting to come out, and I think, again, the previous presentation on the video is probably a good way to go, because it's not dissimilar to what we currently do. There is an issue about the remuneration, the modelling, in the sense of, in general practice, you've actually got your chronic care plan, so you can actually get funding through that. I'm not sure how much it cuts the mustard, but certainly in the public hospital, we had to do something a bit innovative, because it's actually challenging not to get the people to do the work, but to get the money to do it. And the workload is the other issue, is that, again, people are extremely stretched and busy. And so, although it would be fantastic if you could have someone that could spend 2 hours with someone and do all that sort of stuff, it's often challenging because you've got to fit everything else in as well. So it is difficult. And I was just thinking about the list that you had on your, on things that you addressed. It'd be pretty challenging to address many of those things, just because you're probably stretched in doing everything else. And of course, there's the availability of services, which I alluded to, and it does become challenging as you get down sort of more distant from larger centres. So some of this stuff we already do or did do, and so things like rehabilitation does exist. Clearly there are rehabilitation packages or programs. I know, for example, at St John of God in Bendigo, they actually have one which is funded, which has six educational lectures, as well as being seen by physiotherapists, so they get seen by psychologists and they get seen by a dietitian. And so that's something for people with insurance. They can actually have access to that. They get seen by rehab specialists, but again, it's funded because you've got insurance. But that exists. There are private rehab programs. There's certainly something for breast cancer patients through the Anne Cordell Centre. They can see physiotherapists, they can see psychologists, but only if you've got breast cancer. So it's a bit patchy, but there's some stuff out there already. We also have programs through the Cancer Council, Living with Cancer, for example. I know that they're run at all the centres, certainly in Echuca and Bendigo and other places. So there are some things that are available. We've got breast care nurses, we've got prostate nurses, and I know in Echuca we've got the cancer support nurse, for example, and those roles are evolving. You've got your good look good, feel good, stoma therapists. The point that I'm making is you do have some of these components that already exist out there. The difficulty is that if you come into an area and you don't always know where to go, where to find them, so it can be a bit challenging if you're not familiar with what resources are under, but there is quite a lot out there. So what we wanted to do was wanted to do something as a pilot, I suppose, and we started doing it anyway. What was clear to me from that talk with that MD Anderson specialist was that you need to get a core number of people who will drive it. And I think that's really important. Whenever you do these sorts of things, you need somebody who's going to go out there and help you do it together. I don't know, has anyone seen that video, the Lone Nut? You should look it up on YouTube, because it talks about the fact that your first thing to get some change is to find that other person that's going to help you, that lone nut that's going to then help you to become two nuts to drive stuff, because that's really important. So we actually went out there and we picked people that we thought would be able to drive that, and it sort of grew from there. Seriously, look it up on YouTube, it's very good. And we also wanted to establish this program. And so what we did is we basically consulted, we looked at the components of the program itself. We actually liaised with GPs and to at least a sampling of them to look at the sort of the functionality of the actual program itself. And we also spoke to patients about what they thought. And the idea of it was that they would, we focused on breast cancer patients. I know people often say they're already very well resourced, but we just wanted a finite group of people just to see how it would work and then to see what the function of it was. So what we basically did was we put together this survivorship program, which is not dissimilar to what you've got there. And the concept of it was that the patients would actually be assessed by screening tools. Now, you've got one of them in the GP, which is the distress thermometer. We used other validated tools. But basically what happened is the patient filled them out and identified what their needs, requirements were. And then basically from that person, we got a nurse practitioner to actually go through the needs analysis. And at the end of that, they would have a document that summarised their condition, that found their needs analysis, and that would then have a letter that summarised that to the general practitioner with the issues that were required. I'll get Rob to go in great detail, but the idea of it was that somebody within the system would actually analyse the needs analysis, give them the time and space to discuss it, not necessarily solve all the problems, but identify the problems and then actually distribute them appropriately, whether it was to an allied health specialist or to the general practitioner. And also rationalise their follow-up. The other thing that we also plan to do, and I'm not sure because I've seen that document, but not in great detail, is that what we wanted to do was to actually establish a shared care program of follow-up with the general practitioners. And again, start off with one malignancy, but with the idea that we would actually expand that out. But again, in order to do that, once we've worked it out with the specialists within the hospital, we need to consult, because I suppose one of the things about all of this is that it has to be something that's actually acceptable to the general practitioners as primary care givers, because I'm not aware of the work that you do, and so it might be something that's doable, it might not be something that's maybe, if you then multiply it out, that it becomes too onerous. But again, the idea would be that we would also look at that shared care model to decrease duplicity. And probably the other thing too is that sometimes what we in the hospitals can be guilty of is they become dependent on the units. And so sometimes, a bit like Dr. Echuca was saying, that all the other stuff like the blood pressure and the diabetes and that sort of stuff, which still needs to be managed, sometimes gets lost if they start to get dependent on the hospitals. And so for me, that concept of actually sharing the care connects or reconnects or continues the connection with the primary carer so that all the other stuff is missed as well. So I might actually get Rob to talk about the actual program and what it looks like.
Thanks for having us tonight. So, as you can see, Rob's very passionate about this project in Bendigo. I've been based back in Bendigo for the last 4 months, but I grew up in Bendigo, so know the area fairly well. I'm just going to talk you through what the day-to-day, how our program works in the hospital, and obviously we'd be open to feedback about suggestions from general practice as well. So, prior to the appointment, patients are sent out these questionnaires to fill. And then by the time they leave the consultation, we hope that they have a survivorship care plan that they can take for themselves, but also share with their other practitioners they're seeing in the course of their illness or wellness. So this is a busy slide, and I'll just give you a moment just to digest this there, but there's quite a few things that you need to address when you're developing a survivorship care plan. So probably the most important things in this room here is the follow-up plan with the GP and involvement with care, and hospitals are often, particularly in metropolitan centres I've worked, often the communication back to general practitioners about what the expectations are when someone leaves the health service is not always clearly documented. It does have to incorporate referrals to other services, monitoring for late effects, and how to identify the fear of late recurrence. So this is just what our picture looks like, and this has really been developed specifically for breast cancer. So it could be rolled out for other tumour streams, but this is very much a breast cancer specific model. So at the top, it basically says who's put together the program, and basically our nurse practitioner, Justin Hargraves, does this with all of our patients at the moment. Down the bottom on this side here, there's a list of all of the key people that have been involved in their care, including their GP, their specialist, a breast care nurse, and contact numbers for the patient if they need to get back in touch with services down the track. The next page, which is probably the most useful for health practitioners initially when they're trying to see a patient, is to actually, we have quite detailed information about the stage and what type of breast cancer they've had, which is often actually not uniformly documented well in the medical record. We also then talk about what treatment they've had as well, and then it goes down to radiotherapy, chemotherapy, hormone treatment, and whether or not they had a clinical trial. When we see patients in our clinic, what happens at the start is they're booked in to see an oncologist for the first 15 minutes or so of the hour appointment that they have, and we use that part mainly to use, that's facilitate Medicare billing. So they'll see an oncologist who's not their usual oncologist, and that way we can bill as a long consultation, as a new appointment, and that basically helps offset Justin's time to go through this with the patient as well. So usually when I see a patient, I'm often going through this with them as well, and you find it's very variable. There are some patients who are so shell-shocked from their diagnosis that when you're going through this information, they've heard it before, but it often comes across as completely new information. And there are other patients who, by the time they get to this area, they kind of not got this sorted and they want to move on to action plans and referrals as well. So you sort of have to start pitching it a bit sideways once you actually start seeing the patient in front of you. The next page here afterwards basically just has a way of the recommendations for what we recommend as follow-up. So for breast cancer, it's often clinical reviews every 3 to 6 months for the first couple of years, and then 6 monthly up to 5 years. And it also tells them the screening tests they should have done, such as a mammogram and ultrasound annually as well. And hopefully by giving the patient this information, it helps motivate them to be part of their ongoing care. This health and wellbeing plan as well is developed with the patient as well, and this is one where it can be a little bit variable what the patient's symptoms that they identify. And at the end here we have a list of symptoms they've done and the current medications they're on. So there is quite a lot of overlap by what you'll probably find on a normal GP health record as well. And at the end we have basically some yellow and red flags about where we would expect patients to call us or contact us if they had concerns. So notice change in the size of their breast or a new lump or unexpected weight loss, etc. And then in our final bit here, we just have some information to external resources where people can look for further information as well. And then there's just some general recommendations about good health at the bottom. So just going over this here, so this was incorporated into our existing clinic. So basically all of the oncologists are booked in to see a certain amount of survivorship patients per month. And that appointment is allocated. So for example, I might see one of Rob's patients as a new patient, mainly to go over the first few pages of this. And then they'll see our nurse practitioner for the rest of the time. And that can be a challenge sometimes, trying to make sure that we're both running to time, because otherwise we can put each other out there. It tends to be a pretty well attended clinic. Most patients that have gone through the process of filling out the surveys before coming in will turn up and go through there. We are thinking about whether we implement this to other tumour streams, and colorectal would be probably the next most common one that we would consider. When patients come to the clinic, the feedback we've had from Justin, who does most of the referrals here, is about 2/3 of patients are getting some referral onto another service. If you look through here, you can see that probably the biggest things that we are finding in our setting is getting a referral to a psychologist or a mental health care plan, and obviously those things overlap significantly. We do have some access to a psychologist, but not only if there's something else as well as psychology input. So we can't refer someone straight to a psychologist inside our hospital. They need to have something else like lymphedema or something else as well. So the mental health care plan, when people refer back to the GP, often is the way that we can try and get people's psychology input. This is a slide here talking about basically the number of people that have filled in all of the paperwork here as well. And I'm just drawing attention to the bottom here that the most common things that people are addressing is about 1/3 of people have psychosocial concerns, 1/3 of people have mood changes, and then about 25% of people are describing some symptom of sexual dysfunction, and concerns about weight change or aches and pains afterwards as well. Right at the bottom of the slide, which isn't sort of highlighted there, is that we send a letter to the GP, and all of the patients have had a letter to the GP afterwards. Echuca is working, and we had a bit of a chat to Lynn about that today. That was mainly in the setting of having an exercise physiologist, so that's probably a particular part of the program, but probably something more generally needs to be sort of worked out here as well. Yeah. Castlemaine's working on something at the moment. Castlemaine's program is not really looking at the same kind of patients. They're looking at elderly patients and looking at survivorship in elderly people that are diagnosed with cancer. And I don't have a good sense about where Swan Hill are up to with things like that.
It's more like basically really basing on physical fitness. Yep. So all of these, this is an example of how, people try to do their own thing in the same space, and basically these were funded by various funding opportunities. So, Bendigo did it through Safer Care Victoria, but we started it anyway, so we got a grant from that. And then at Echuca, I think you got yours through, was it LMIX? Yeah, okay. And then Swan Hill did one, and then Castlemaine did one as well. So Castlemaine was basically based in the hospital, but it was community-based. And it was really just tying together the allied health professional they had and giving them a vehicle to analyse their needs, again, mainly sort of based on sort of physical aspects of it, and then providing with a program. Yeah.
So obviously survivorship is an important unmet need, and a lot of people are involved in people's care, not just when they're having their acute care done and down the track as well. And every site sort of has their own slightly flavour and priorities of what they want to achieve at the moment as well. And you do need a key leader at each, whether it's someone here, someone in Bendigo, our suite, someone like Rob, someone like Lynn, someone that is able to help drive that through, because it really requires a lot of motivation to be able to tie together a few different specialties as well. I think that's really all we wanted to talk about now. We're very open to having a chat or talk or questions about, or suggestions about how we can improve things, really.
I mean, I suppose just to make a point that with the idea of that what we were doing was to basically have that opportunity to do that initial needs analysis, and then, was to actually have that needs analysis done, to give that space, and then to utilise the appropriate resources that were out there. So again, just identifying them based on the patient's needs analysis, and then feeding them into, like I said, it might be sending them back to their general practitioner for a chronic care plan, but saying, this is what we found, these are the areas that, that might fit into your field, are you happy to take on the baton? So it was just a matter of just setting up that sort of space. But I suppose what will be interesting with this program is how does that work, because that's also being developed again in parallel. And I think that's one of the challenges now. We've got like all these different components. How do they all fit in together?
It would be likely it could be a hospital setting or thing, because we, particularly with the fatigue, we get so many old people. They go to a couple of the appointments and they might have 10 things on the list, 10 different specialties to see, and they just can't finish all their appointments. Haven't got the energy.
Just locally, our cancer support, care coordination nurses, we tend to keep patients on our books as such for a couple of years. So it is a very much a survivorship model of care coordination through that time to that degree. Where we probably haven't formalised, there's no care plan that we can share. And so, and for us, and I hear what you're saying is how do you link in what do you expect from the people that you're sharing that care with? So if you're then sharing a care with a GP, are you hoping to reduce the number of clinic follow-ups over time with the specialist and having more of that done with the GP, or I guess that's we don't quite understand that relationship and how that.
Because the travel becomes a big
And it's resources as well.
So, I mean, there's two things. So the actual survivorship clinic that we do currently as it stands is basically it's a needs analysis. It's one, to consolidate their diagnosis to make sure they understand where they're at that point in time. Two is to find out what is the damage fallout and what are the issues. And then three is, where do they go for that? And again, in many cases, it's appropriate to either be referred to an allied health resource, and again, it might be, if it's in Bendigo, it might be to the Castlemaine rehab program, it might be back to Swan Hill, it might be to their general practitioner. And then the other component, which we will do it shortly, is the follow-up, which basically is, again, realistically, it's not well coordinated. And so the issue is that sometimes some of us will actually say, well, when is your next surgical review? Okay, right, I want you to push that one out. Like we have done things, for example, where with breast cancer patients, after the radiotherapy is finished and they do their 6-weekly review, they don't see the radiation oncologist anymore, because we had 3 people involved in the care and it's multiples of 2. So it didn't fit. So we said, you don't have to see the radiation oncologist anymore, with their permission. And so there's just 2 providers, but the idea is that we might potentially reduce it down to the medical oncologist and the general practitioner after 3 years. But it's to rationalise the follow-up, but also to again help with the resources. It takes travel for some people, and also it's unnecessary. And they could be actually seeing other people, with a new diagnosis rather than seeing someone they don't need to see.
So what I've noticed, particularly in regional areas, whether it's here, I also go to Kerrang once a month as well, is that By default, without any formal structure, medical oncologists have often taken a lot of the survivorship on regional areas because surgeons don't travel regionally, and then patients. So, for example, there are a number of breast cancer patients here that don't see a surgeon again. There are a number of patients in Kerrang that don't see a surgeon again either. So, again, that hasn't been formally thought up as a plan, but it's basically been something I've just noticed as a pattern of care. There are more extreme models where they're actively trying to outsource from hospital care to primary care. The difficulty is you need to have. I can understand that if I was a general practitioner trying to keep on top of 300 different things at once, having to do follow-up for breast cancer, which changes every 2 or 3 years as well, if I'm only seeing a patient every 2 months or 3 months, it'd be very hard for me to quickly jump into an algorithm. At the Austin, they have a nurse who they're trying very hard to get people out of the hospital setting, and so you see an oncologist. Ideally, the plan is to see an oncologist once a year, a surgeon once a year, and the general practitioner does the in-between follow-up with quite clear flags to swim in between those visits and when to escalate. And they've had some people on that program, but I certainly wouldn't say it's been a huge take-up, and often the diff is that patients don't want to have that model of care. They get very attached to the health system. I'm not sure if what you guys have noticed, locally.
I do like that initial follow-up.
Yep.
In that first 12 months. Then after that, they go to where or
Yep.
the oldies want to, do I really have to travel? It becomes a bit of a buggy.
But I reckon if you actually have a plan where you say this is what's going to happen, and you set that expectation up from the front, then that's how you set it up. So the idea that we're playing with is that once they get to 3 years, they see the oncologist once a year with their imaging, and then they see the general practitioner in the other 6 months. Because usually by 2 years, the review appointments get to be 6 monthly anyway. And then again, for some malignancies like the triple negatives, which they're not going to relapse at 5 years, they're probably not going to relapse. Or the HER2 positive, ER negative, again, probably at 5 years, they're probably okay. Then they'll just be discharged completely and just see their GP once a year with breast imaging, which is what we're toying with. So the challenge is that we've got the program. We're currently working with people to make sure that it's a package that is easy to follow and is palatable. And then we need to go speak to all the people playing and making sure everyone's happy. You know what I mean? So that's the other issue, that you've got to consult with the general practitioners and the surgeons and everybody else to make sure that everyone knows about it and everyone has an opportunity to have input. So we're sort of getting to that point at the moment, but that's something that we'd like to do. So we're looking at that. So telemedicine's already being looked at, on a number of levels. So it's currently being trialled in Bendigo with Swan Hill. It will be trialled in Echuca. It's also being looked at for access to clinical studies. So we're currently involved in a trial with the BCCC. So, for example, one of the other things that are a disadvantage to patients involved in clinical studies is that we try to offer people clinical studies, but the uptake is about 3 to 4% in regional Victoria versus about 12% in some of the hospitals, and it's because it's expensive, it's time-consuming. And sometimes it's just too hard. So one of the ideas that they're going to be doing is, and I think it will be successful, where your patient actually receives treatment where they live, but what they do is they have their consultations with the principal investigator via teleconferencing on the other side. And what that means is, so at the moment, if you've got a clinical study and it's got a very specific subgroup, it can be very difficult to accrue. But if you could actually treat anyone in Victoria where they live, you could accrue much broader, but it means also that the people have greater access because they don't have to have the cost of the petrol and the travel and the wait. So if it's successful, it'll be extremely powerful.
GPs can charge for teleconference, is that
Yeah, they can. Yeah, exactly right. So we are looking at it. It's a matter of working out how best so it has been used already in places like Queensland and that sort of stuff, and certainly used a lot in psychiatry. But I suppose it's a matter of just working out how it best works for this sort of area. But it is being looked at seriously as it is with throughout the state. So it's actually happening. It's being trialled to work out the efficiencies of it.
The difficulty we sometimes have with the survivorship patients is, so the Swan Hill at the moment program, which is still in its infancy, they're specifically not doing follow-up for breast cancer because you can't examine a patient via tele. So it's mainly being rolled out for people that are on treatment, that it just saves them a review, and there's a chemo nurse in the consultation as well, so that's sort of hands on the ground. In Queensland, they have GPs on the other end of the phone, and they do much more broad things. And in Queensland, they say that they do palliative care, end-of-life family meetings via telehealth. I don't think Victorians are quite at that stage of kind of accepting that kind of level of support at this stage, but there is a lot of flexibility in what you can do.
The other thing we're probably also looking at potentially is using video conferencing in the emergency department as well. Sometimes, or in day oncology sometimes, for example, where patients will turn up and we'll get a call from the nurse to say that they're not well and they've got these sorts of issues, and the idea would be that we could actually interview and see the patient directly rather than going through a third person where you get the questions repeated multiple times while they're sort of on the phone. But the idea is that you could actually see them, because often when you look at somebody, they've got a neurological problem or they look unwell, just looking at them gives you a pretty good idea that something doesn't look right, or they look pretty unwell. So I think that would be, again, quite powerful. So we're currently looking at those aspects as well.
Because that needs to do with the MTs, so the MTs are being endurance, the physio there, or the orthotist or whatever, so you could actually, the doctor could work from there.
Yeah, and because you can actually bill for it, it does. It means that if there is any, because unfortunately it's about the funds as well. And I think most people in this profession already probably donate about a third of their life doing stuff for nothing. But you've got to have some sort of financial sort of support, and video conferencing can potentially take extra resources, having people on the other side of the, so it's sort of helpful to use that resource.
Is it tricky if the specialist is running behind, or the other people in the conference call and the GP, has a certain amount of time, that becomes a bit of a...
See, the only thing that's interesting actually, because I went to, there was a presentation at Echuca and there was someone that was an oncologist, and I said, what do you actually do? And what they do is, so they run a clinic, and if they have an interview with a GP, they stop that clinic and freeze it, and they'll say, I'll be back in 15 minutes. They make someone else wait, but they don't make the GP wait. Because I asked them how they did it. So, if things fall behind. But again, I get the impression they're quite selective. So if they've got something, it's not going to be an hour consultation. It might be something that might be 10 or 15 minutes. You know what I mean? Particularly if you're not going to examine the patient, you're going to just take your history and then just say, right, this is the plan. Can you please assess that patient, examine their chest, look for lymph nodes, and call me back if there are any problems. If it's okay, this is the plan. So I think it's a different structure to the way it's done. But that particular oncologist said, I just stop what I'm doing. I say, excuse me, I want to be back in 5 minutes, 10 minutes, and then they leave. So they don't make the GP wait. Because I asked that same question, if you're out of sync, who waits? So that's apparently what they do. Yeah.
So you say you share the breast cancer survivorship care plan with the GPs.
Yeah.
Are you sharing them with breast care nurses that are around in the region?
So so at the moment what we've done is we have, but we've again, the problem was we weren't sure how big it was going to be, and so the nurse practitioner actually sees a lot of clinical loads. We just restricted it, at least initially, to the people in Bendigo. The other reality is that all of our documents actually go on the digital medical record, so it's already there. But certainly, that would be appropriate to do that. And what happens is, as well as this, the GP doesn't get the whole survivorship thing. They just get the medical stuff and the assessment. They don't get the websites and that sort of thing. But they also get a letter that summarises the findings, so they can just scan the letter if they want to and just says, these are the points that we found, and these are the things we'd recommend. And if you could do the following, if you could oblige, that would be great. That sort of thing. Yeah.
There's some really interesting super clinics in Melbourne now. I've found you guys would know all about it, but like with a physio and an OT and a wound nurse and everything all in the one place. Just amazing.
Yeah. Yeah, I think like again, the way that at least in Bendigo, the cancer centre's been set up, that as much as possible, it's in the one-stop shop. So all the allied health live in there, and the radiation oncologists live in there, and the medical oncologists live in there, and the surgeons they transitly come in and go out. But it's like I said with my previous example, you've got to be extremely well resourced financially.
Yeah.
And it is great to be able to do all that sort of stuff. Although having said that, sometimes when you do everything together, some people find it actually overwhelming. Like we've tried to do that, if someone has to see, like we have at the moment a clinic for lung cancer, which has got the surgeon, the respiratory physician, the onc and the radiation oncologist, and if they have to, they'll see 3 of them at the one time. But also for some people, it's like overload too. So it's always challenging, isn't it? Like, it works for some people, but not for others. But, that idea of trying to...
It's like a super visit.
Thank you. Yeah, well, it was probably more the fact that the reason why that was done was more to decrease delays so that there wasn't, we'll see that person and you come back in 2 weeks and then it takes 6 weeks for something to happen.
And then, problems with communication between all.
Yeah, so that's why that's being done. And again, we're trying to replicate that. But it's interesting, when I was at Peter Mac, in some of those, giving it away. When I was at Peter Mac, and they had those clinics, there was an inefficiency in them as well. You know what I mean? So specialists might see 4 people in a session, whereas we might see 12. You know what I mean? Like, not 12 new people, but you know what I mean? Like, there's a bit of waiting around. So it's always challenging how to do something that works well for the patient that isn't really labour intensive. Yeah.
I think particularly with the lymphedema from Bendigo, there's that nice match when people are coming back for their radiation, that they actually, come in for their lymphedema education. So there's a nice timing, so it isn't actually as much.
Yeah.
It's not that way, it's the one-stop shop, but there's also this down the track when they come back in.
Yeah.
We've got 10 minutes still out of the week. So if anyone has any more questions for any of the presenters, Ray or us or Rob?
So we don't get all 10 pages of that. We only get, you said the GPs get a summary.
Yeah, so there's a letter. So sometimes people, so Justin will actually write a summary, a one-pager that says, this is what we found.
Yeah.
But also what happens is, so there's the way that we did it or constructed is that part of it was information specific about the person, and then the latter pages was just generic stuff, like, for the individual, if you start to notice some increasing breast swelling or a lump under your arm or, progressive unexplained weight loss, for example, then these are the things you as the patient would be concerned about, and they're the red flags that you need to go seek your GP's information about. And then there's websites like, support groups. So we didn't think that the general practitioner would want to keep on receiving that sort of stuff. So it was more the summary and then the actual outcomes from the intervention itself rather than the educational components to it.
So in that letter you identify the specific needs of that patient?
Correct.
It could be mental health.
Whatever. And then
your expectation is the GP will then follow that up with whatever resources that GP has within this.
So for example, it might be something like they've got fatigue, then then Justin might actually refer them specifically to the OT within the organisation to do that. Or if it's someone from a distance, like where that's not convenient, then it might be something to say, are you able to refer that patient to their local OT service? So if there's something that Justin can do that doesn't then put all the onus on the general practitioner, it's done. Or if there's, for example, I don't know, someone with problems with sexual health issues, and there's someone that can do that within the organisation, they might refer it. But if it's something that, so for example, I need access to a psychologist in a mental health program, then that would be articulated in the letter and requested of the GP if they could make an appointment for a plan, for example. So all of the assessment is articulated in the letter, but then there are things that are felt to be transferable to their primary care physician, and that's what would be articulated in the letter. But again, sorry.
Sorry, no, I'm just thinking, these patients demand a lot of time and effort and attention because they're coming from the oncologist with all this stuff. As Rob was saying, it's an overwhelming stuff. And they come to the GP And you can imagine what's happening in the GP surgery. They're running an hour late. And this woman has turned up the document, and you just say, "Oh my God."
So what we actually do, what you do suggest is that they, for a start, what they do is the letter gets sent to the general practitioner, and then what happens is we would say to them, you're going to need to make an extended appointment with your GP to discuss this aspect of it. And the expectation isn't that it's going to get fixed. It might be just to say, well, this is the plan. Okay, you need to come back next time. But again, I mean, when we did the consultation with, and we did try to speak to some of the GPs here as well, it was pretty clear to me that, you know, you guys are busy too. So to actually say, well, we've found all your problems, now go see your GP and let them fix it all up would be, you know, inappropriate. So it was about trying to utilise the resources as best we could, and realistically, I think that's the other issue, that there are some things that are clearly that are based in the community that should be utilised and that we don't have access to, and the general practitioner is the person that is the mediator for those sorts of things.
We have a lot of resources in this town, from exercise physiologists to counsellors.
Well, see, even like with counsellors, to be honest with you, I mean, we've got one psychologist who does breast stuff. I wouldn't know who the social psychologists are, you know, in the community, who would be appropriate, to be honest with you. So that's one thing that we would often refer to the general practitioner to discuss a mental health care plan.
So this care plan is going to come in from this care plan is going to come in as a chronic disease, isn't that right?
Yeah. So that's it.
So every 3 months, it's a sort of limit put on by the government.
So I have to say that the one done by the PHN, I'm not that familiar with how it works. The one that, what we try to do is partly self-digested. So we've said that we've got someone, we've used 3 validated tools. These are the areas that have been identified. We've tried to solve some of these issues by doing these referrals, but these ones we can't help with. Are you able to assist us with this?
So when we had a cancer clinic, she actually, there was a few people that were there at the time, and it was pretty much just a care plan, quite extensive.
Yeah.
Like,
So
the stuff that you had in the wardrobe, there was a lot of.
And so you can still eat the bits that aren't relevant.
So if someone has already got a care plan, say diabetes or ischemic heart disease or whatever, and they come in with this, they'll then become a new care plan. So they'll
This is the problem, you've got a complex patient who on top of it develops their cancer, and that's where time just blows out.
Yeah, exactly. You have to be a big one, but you can imagine, as you said, it becomes a complexity just.
Some of these patients, though, with those other complicated issues, the cancer is often the less complicated. Like you're taking all these other things that are often actually intrinsically much more complicated, and that's just part of it.
I was going to ask about information and transfer of information. You guys will send us the plan, what our expectation is. You'll send us a summary of what's actually gone on. We'll do the care plan, but I guess what do you need back from us apart from the fact that we're doing that? So let's say we send to a psychologist. Sometimes we don't get much information back from the psychologist about what the specific treatment is.
But I think that we receive care plans. So, so I suppose if you're doing those sort of things, and I read them when they come back. They say these are things that we're doing. So I suppose if those things are, we'll often ask the patient anyway. But I suppose it's really just things that if there's something that's having an impact on how they're functioning, probably just need to know those critical aspects.
And if we do an assessment, do you want like a copy of our progress notes or things like that? Is that the sort of thing that's going to be helpful as far as feedback? Something a bit more detailed than what's in a care plan? Is that helpful or not?
I suppose for me probably the things that I sort of need to know are some of the in terms of patient management, some of the critical events that have happened. You know what I mean? Things like if there's been significant alterations in their medications that might be influencing what we do, for example. I think they're the sorts of things. But I don't know about you, but I know that if there's anything sort of significant, we're happy for just a one-liner in a fax, for example. We often get information that way. Either people give us a buzz, or they'll just say, this has just happened. Can you, comment on that or deal with that, or what do you want to do about that sort of stuff? Because I recognise that people are very busy. So I suppose it's just the critical aspects of their management that we would need to know as we continue to manage them. I mean, in the case of, it's probably more critical when they're actually on active treatment, you know, when things happen, you know what I mean?
And we often rely, particularly working with Echuca, Swan Hill, Kerrang, a lot of the times when people come to hospital, we might get notified they come to hospital and involved in the initial plan, but we're often not told again until they come and see us again. So it is helpful. But basically, I don't think we ever say we get too much information from primary care. So, I mean, all information is helpful there as well, but we don't expect you to spend an hour at the end of the day sending us a copy of all your progress notes there as well. But certainly, if there was things that you thought were relevant to us.
I mean, I'll give you an example of someone, you know, basically was on chemotherapy for their bowel cancer and they had AMI. That might be helpful to know about that sort of stuff, because it could have been our drugs causing it. Yeah.